Welcome to part 4 of the lecture Immune Deficiency. Here we will present the secondary immune deficiency. As I mentioned before, secondary immune deficiency is more common and results from an underlying acquired causes. And the causes here are so many. You get the infections like viral infections, the immune deficiency virus, the HIV, cytomegalovirus, the CMV, Epstein-Barr virus, and the rubella. Also chronic bacterial infections like TB, tuberculosis, and parasitic infestations in malaria and leishmania. So infections can cause secondary immune deficiency. Prematurity and old age, malignancy like lymphoma and leukemia, drugs like the anti-malarial drugs, glucocorticoids and cytotoxic drugs, the radiation therapy, protein-calorie malnutrition, so malnutrition itself can produce secondary immune deficiency, chronic renal failure, protein-losing enteropathy, metabolic diseases like diabetes mellitus, excessive burn, splenectomy, and plasmapheresis. Here we will focus on the human immune deficiency virus and acquired immune deficiency disease, the AIDS. In infants, the virus affects the immune system in many ways similar to PID. Therefore, it is always put in the differential diagnosis of any infant suspected to have primary immune deficiency, especially the severe combined immune deficiency. Here, preview with you the structure of the virus. The HIV virus is a member of Retroviridae family, lentivirus genus. The HIV genome is a single-stranded RNA, and the viral code or the capsid here, you can see it, it's in this area. The capsid, it's like a bullet-shaped and is made from a protein, the P24. Inside the core, there are 3 enzymes required for HIV replication called the reverse transcriptase, the protease, and the integrase. Inside the core, you can see the virus itself. It's composed of 2 identical RNA viruses. Here is the shape of the bullet shape of the capsid by the electron microscopy. What concerns us is that mode of transmission in pediatrics. We can get it through sexual contact, like if we have a child abuse, or in adolescence. The blood transfusion, however, this is very rare now because there are very strict rules concerning the blood and blood product checking for HIV. And then we have the vertical transmission. It can occur intrauterine during pregnancy, 30%, but during the intrapartum period, this is the highest percentage of transmission. It reaches up to 70%. Then we have the postpartum, the breastfeeding risk, whether to breastfeed or not, the mother infected with HIV. It is about 28 of infants born to mothers of HIV who acquire the infection while nursing. They get the virus, which means that during viremia, this is the highest risk to transmit the virus from the mother to the infant. Meanwhile, it occurs only in 18% of infants born to HIV-infected mothers before pregnancy, because probably these mothers will be on treatment. The risk factors influencing vertical transmission, we have preterm delivery, less than 34 weeks gestation. The birth weight is less than 2 kilos and 500 grams. There is rupture of membranes for more than 4 hours. The vaginal delivery, the low maternal antenatal T helper cells, and the maternal viral load, which means the number of copies of the viral genome, the RNA, which can be detected by PCR. Here, if it is higher than 50,000, it is a high risk. The number of T helper cells and the number of the viral copies represent that the mother here is in active viremia. So during active viremia, there is the highest risk of transmission. So how does the HIV affect the immune system? First, HIV specifically attack the T helper cells, the CD4. The HIV antibodies produced by the immune system are unable to overcome the infection. Over time, HIV progressively weakens the immune system, and here the individual becomes immune deficient. The weak immune system can no longer effectively defend the body against opportunistic infections, and that's why patients with HIV have tendency or increased susceptibility to opportunistic infections. The clinical features here, I highlight some of them in red, like the failure to thrive, oral candidiasis, chronic diarrhea, recurrent infection with opportunistic organisms, and lymphopenia, mainly T helper cells. If you remember, in part 1, we have the severe combined immune deficiency, and these symptoms or clinical picture, it is very similar to those of the severe combined immune deficiency. That's why we put the HIV in the differential diagnosis of severe combined immune deficiency. Also in HIV, there is lymphoid interstitial pneumonitis, the LIP, Pneumocystis pneumonia, the PCP, there is generalized lymphadenopathy, Hepatosplenomegaly, progressive developmental delay, which can occur later after the HIV turns to be AIDS, the Parotitis, cardiomyopathy, chronic hepatitis, nephropathy, and malignancy. So you can see it affects all the body systems. The immunological markers which we have to look for the recent infection. Recent infections mean that within weeks or the maximum 1 month, here we get the viral load. The viral load is the number of HIV RNA copies detected by PCR. This test is very sensitive for early diagnosis and follow-up. Then we have the T helper cells, the CD4 cell count, the T cytotoxic specific for the HIV, and the HIV antibodies, the P24, the protein 24, and anti-envelope antibodies. This test is not sensitive. It appears after 3 or 4 months, so it is not a sensitive early test. Now we come to treatment of HIV infection. Unfortunately, there is no curative treatment. The treatment provides control of the infection and offers a better quality of life. The prognosis with treatment is better. And this treatment is in the form of highly active antiretroviral therapy, the HAART, and treatment of infection, as well as the current and prophylaxis. The drugs used for the treatment of HIV is the highly active antiretroviral drugs therapy, the HAART. This here we use a combination of 3 or 4 drugs. The drugs aim to block the viral replication. So we have the reverse transcriptase inhibitors, like nucleoside analogs, the zidovudine, didanosine, sidofudine, the abacavir, and the lamivudine, or the non-nucleoside analogs. Here we have the protease inhibitors, and we use some of the adjuvant drugs like the interleukin-2, which promotes the maturation and function and development of the T helper cells. Sometimes we use the hydroxyurea. We use the granulocyte colony stimulating factor, the GCSF, to enhance the proliferation of the granulocytes and neutrophils, and the L-acetylcarnitine is tried for patients to delay the developmental delay. So, take-home message. Primary immune deficiency is not uncommon in Egypt. Many patients die of infection before diagnosis. The key to detect primary immune deficiency diseases is to consider the possibility. Keep a high index of suspicion and put primary immune deficiency diseases in your differential diagnosis of any case with persistent or recurrent infection, atopy, or autoimmunity. Careful reading of the lab results, the complete blood count and the immunoglobulins, and correlate with the age-matched normal levels, early referral of suspected infant or a child to a specialized center for accurate diagnosis and management. Early initiation of treatment is essential for preventing significant disease-associated morbidity. For secondary deficiency, this is more common than primary and should be excluded before the diagnosis of primary immune deficiency is established. The detailed history might uncover the underlying condition affecting the immune system, such as infection, malnutrition, use of immunosuppressive drugs, and so forth. Measurement of viral load by PCR is the most sensitive test to identify HIV infection. No curative therapy for HIV infection so far. The HAART control viral replication and provide a better quality of life. Here are some useful links that you may look at for the primary immune deficiency diseases. And please be ready with your questions in the next face-to-face session. Thank you and good luck.